Welcome to Vital Voices, where we bring you expert insights and practical advice to empower healthier lives. Today, we're diving into a topic that affects millions worldwide, and particularly here in the Bahamas and the Caribbean: diabetes. With rates on the rise in our region, understanding this condition and how to manage it has never been more important. I'm your host, Alexis Burrows, and joining me today are two exceptional experts: Dr. Carmen Cartwright, a leading endocrinologist who specializes in the diagnosis and treatment of diabetes, and Mrs. Shanishka Cambridge, a registered dietitian nutritionist whose work focuses on helping people make sustainable lifestyle changes for better health. Together, we'll explore the prevalence of diabetes in our community, the types of diabetes, who should get screened, and the importance of knowing your status. We'll also touch on advancements in therapies like the much discussed Ozempic and how technology is transforming diabetic care. Most importantly, we'll share practical advice on lifestyle changes to help manage or even prevent diabetes. So grab a cup of tea, settle in, and let's get started.
All right, so let's start at the beginning, and the beginning exists a little bit before even the questions I have here. So I apologize, because I'm always interested in how people decide to get into specific areas of medicine. Because I think there tends to be a lot of interesting stories in the background. So I'll start with you, Dr. Cartwright. What made you want to get into medicine generally, but then more specifically into endocrinology? And then Shanishka, the same thing. Like, what made you want to become a dietitian, nutritionist? What made you guys want to get into those spaces? So we'll start with you, Dr. Cartwright.
Sure. So thanks again for putting this meeting together, because obviously this is Diabetes Awareness Month and tomorrow is World Diabetes Day. So it's very fitting for us to have this conversation about something that is affecting quite a bit of our population and our nation, and truthfully the Caribbean as a whole. So for the reasons that I might have decided to get into medicine, as long as I could remember, I know that sounds so cliche, I felt that I wanted to be in a position to help others. And I enjoyed the aspect and the biology behind medicine itself. To be truthful with you, at one point I thought I wanted to be a pediatrician. I thought I wanted to work with kids, but I kept my mind open. And once I went into medical school, I quickly learned that that was something I did not want to do. Again, kudos to our colleagues there who have the strength to do that. It's hard for me to see other kids suffering. Obviously, it's also hard to see adults suffering, but it's not as hard, I guess. But for endocrinology specifically, I did not know that until my medical school rotations.
Okay.
So I rotated with a physician in Miami. Excellent doctor, still practicing, I think, into his 60s, 70s at the time that I rotated with him. But the rapport he had with his patients, the way he would educate his patients, because I think a large part of what we do as endocrinologists is education, which is what I really enjoy. So he sparked the interest. Once I went into internal medicine residency, you can then pick specialties of where you want to rotate. And I asked repeatedly to go into endocrine service. So shout out to Dr. Domingo in Aventura, Florida, who again fostered that desire and the interest to go into this specialty.
Okay. Shanishka?
Thank you, Mr. Burrows. Thank you for inviting us on this platform. My journey to becoming a registered dietitian nutritionist and board certified nutrition specialist was very unique. In high school, going to Queen's College, I was a science nerd. I enjoyed taking all of the sciences, and naturally one would think, okay, go and do a biochemistry degree in hopes that you would go into medicine. So there I go, enrolling in a biochemistry degree program, and one of my biochemistry professors, Mr. Rock Ordman, he was also a nutritionist. And I took one of his courses, Biochemistry of Nutrition. And during that time, I became very intrigued and excited to learn more about how biochemistry is actually at the foundation of nutrition. And that sparked my interest. But I still completed that bachelor's degree, but I decided at some point I would go back and pursue it and see how I like it. And here I am today.
Okay, awesome. I do find that to be, like I said, it's always an interesting conversation, because I've done this in different spheres, and I do think one of the things that always stands out to me is the role of mentorship in the space of medicine. And so, my charge and challenge to people, especially now, is like you're now in that space, is to carry on that same thing, because like I said, I've heard a lot of physicians say it was this particular, whether it was a rotation, whether it was spending time in a particular part of internship, whatever it is. And that kind of was just like, I want to go over here. But yes, indeed, shout out to all the pediatricians. My sister-in-law is actually a pediatrician, and I don't know how they do that. Because there is a difference between watching a kid suffer through something than watching an adult. So I do get it. So yeah, that's good. It gives us kind of a ground floor to understand, the who's and how's and why's as you got to the places that you are. So, let's get into this conversation. Like you said, we are in World Diabetes Awareness Month. So let's set the stage. I think, we hear a lot of times that, diabetes is something that affects our population at a pretty high rate. But what exactly, what is the prevalence? How prevalent is diabetes in the Bahamas and I guess in the Caribbean at large? And why does it seem like our region, our people are so particularly affected by the disease?
Understood. So to start off with, unfortunately, it's kind of a paucity of data out there in terms of what's been studied and what's been documented. So I'm hoping also as time moves on, we'll have more and more data to really answer these questions. But at least as of the 2019 STEPS survey that was published, that was a joint effort between the Ministry of Health, World Health Organization, and the Pan American Health Organization, that sent out a survey to Bahamian households to try and understand non-communicable diseases. So these are diseases that are not infectious and easily spread one person to the next, such as diabetes, hypertension, and so on. Right. And what they found from this survey is that about 11.5% of our population at that time was living with diabetes. When you look at the latest data from NIH, that's National Institutes of Health out of the United States, the Caribbean as a whole, they range anywhere from 12 to 18% prevalence. So we're on the lower end of the cusp. But I would say that's also data that's several years old, right? To say how well is it actually communicating to our current day statistics for patients being affected by diabetes. Another portion that survey was able to elucidate was that about just under 7% of Bahamians are also living with pre-diabetes. I know, again, this is diabetes awareness, but pre-diabetes is also really important for us to realize and see and catch early so we can make those changes for those patients so they don't progress to diabetes. And, it's daunting to think that with such a small and great nation that we have so many that are affected by this disease, which I think a lot of it, unfortunately, lends back to our current lifestyle. In terms of what about us as a Caribbean and as the Bahamas, why are we at a higher risk for diabetes development? To be truthful with you, in that same STEPS survey, they were looking at the prevalence of obesity in our country. And they said the obesity prevalence up at that time was 71% in comparison to 62% for the rest of the Caribbean. So unfortunately, we as Bahamians are larger. We're also more sedentary in that our lifestyles are, we're busy with life, but we're not necessarily always busy in the activities that are better for our life. And those are major risk factors for development of diabetes.
You mentioned lifestyle, obviously sedentary. You mentioned the risk factor of obesity. Are there any other genetic factors in our environment, in our population that contribute to the higher rates?
Most definitely. So if you look at American Diabetes Association standards of care, when they talk about who should be screened, who's at higher risk, they talk about different ethnic groups and races. They talk about African Americans, but obviously we can translate that to Afro-Caribbeans for our people here in the Bahamas and in the Caribbean, in that there's a disparity, that there is a greater risk in that particular ethnicity. I would say also, when you have a first degree family member, so that's your mom, your dad, your brother, your sister with diabetes, your risk increases already 2 to 3-fold compared to somebody who doesn't have a family member with diabetes.
Oh, wow.
If let's say you then have both on your mom and dad's side a history of diabetes, not even in first degree relatives, that again increases your risk. So these are all things that you have to think about when we talk about the risks and who should be screened, because that puts it into perspective.
Right. Because then obviously the more people that have it, then the likelihood that more people get it because of that hereditary genetic component of it.
Correct. But also in that, if you might think about attitudes towards food, practices and lifestyle, beg your pardon, are also inherited and passed down through families, right?
So if you're the two meats, and 6 sides on a Sunday,
exactly,
type of family, if your Grammy did it, your mommy did it, then more than likely
it continues, right?
And so you're right. The lifestyle and that kind of habitual component of it also comes into play even outside of genetics, because it's just what you used to. This is what you've been doing your whole life.
Correct.
So you mentioned pre-diabetes, which I kind of want to loop into the next question, because we talk about the types of diabetes, and yes, people will likely have some general understanding if you have type 1, type 2, but I want to fit in kind of where the pre-diabetes fits into that space as well.
Sure.
But, kind of give us a rundown of the different types of diabetes, how they're similar, how they differ, and then where does pre-diabetic fit into that space?
Sure, no problem. So it would probably be best to think about 3 major categories of diabetes.
Okay.
Type 1 diabetes, type 2 diabetes, and gestational diabetes.
Okay.
There are definitely more types, different variations, different background reasons, apart from just genetics, lifestyle. Sometimes the patients are post particular types of procedures where their pancreas is injured or removed. Patients who are post-transplant and need chronic transplant medications, that increases their risk of diabetes. So there are more than that, but that's at least a good place to start.
Okay.
So with type 1 diabetes, those are people that are generally diagnosed at younger ages, adolescents, but it can be up into adulthood. And in type 1 diabetics, the big difference for them compared to type 2 diabetics is the pancreas, which is the organ that sits in our body just below our chest at the upper part of the abdomen that creates insulin. That's the hormone that allows us to control our blood sugars, working all the time. We're not even thinking about it, but it's doing its job. In type 1 diabetics, they have autoimmune disease that attacks the cells that make that insulin, so they stopped making it. So type 1 diabetics will generally be patients that are diagnosed earlier, and they are more likely to have more incidences of being hospitalized specifically for diabetes-related dysregulation or lack of control.
Okay.
Not to say that type 2s may not also end up in the hospital. They definitely can for different reasons. So a big way, some patients will tell me, oh, doc, well, my family member was on insulin. They must be type 1. Not necessarily. So every type 1 patient, type 1 diabetic, is on insulin, but not every insulin requiring patient is a type 1.
Okay. Understood.
Because with type 2 diabetes, what's happening there is your pancreas is still working. It hasn't been injured per se by an autoimmune process, but your pancreas is having to work harder. It still makes the insulin, but it doesn't make as much as it's supposed to, and it doesn't work as well. It's called insulin resistance.
Right.
So type 2 diabetics are generally diagnosed later in life. However, unfortunately, we are seeing more and more younger adolescents and even children diagnosed with type 2 because of obesity.
Right.
Because obesity and the fat cells drive insulin resistance.
Okay.
So type 2 diabetics generally, depending on where they are in the spectrum of their disease, might get away with just oral medications. Some patients can get away with just lifestyle changes. And then they may at some point end up on insulin.
Okay.
Gestational diabetes is where you have patients that are diagnosed with diabetes of pregnancy. So solely by the fact of hormones secreted by the placenta, which is what feeds baby, it increases insulin resistance. So all women are screened for gestational diabetes around 24 to 28 weeks in pregnancy. And then for pre-diabetes, I see it, as a spectrum of type 2.
Okay.
In that these are patients that are having insulin resistance, but we are catching them much earlier than at the point where they're officially diagnosed with type 2. Because 50% of people who are diagnosed with pre-diabetes in their lifetime could progress to diabetes. It doesn't mean that they have to, but they definitely can. So that's a big place where we can try to capture them earlier and, nip it in the bud before it becomes a problem.
Yeah. I mean, like you said, when you think about it, with 11% of the population having diabetes and then 7% being pre, that's essentially almost 1 in 5 people that you encounter is either diabetic or pre-diabetic.
Right.
Is there one or the other that is more common in our region in terms of type 1, type 2?
Excellent question. So at the moment, again, for paucity of data, I can't say it directly.
Sure.
I will say, however, the latest data that I was able to publish from Ministry of Health that looks specifically at patients that were discharged from the public hospital authority, so I guess directly mainly from PMH.
Mm-hmm.
At the time of diagnoses, were they discharged with or without insulin?
Mm-hmm.
So in that way, you can't, again, say if it's type 1 versus type 2, right? We already talked about that part, that patients could, all type 1s need insulin, but not all patients on insulin are type 1s.
Mm-hmm.
But it could also tell you that if more people are being discharged on insulin, because it was more than half of the people were being discharged on insulin as opposed to oral medications, that tells us it's more a level of severity of diabetes.
Right.
But I can't answer directly, unfortunately, type 1 versus type 2.
Understood.
In terms of the numbers.
Okay. I think you mentioned a little bit already, or you kind of alluded to screening, right? Now, I don't know if I'm familiar offhand with the screening process for diabetes, but for our listeners, and I guess a little bit for me, who may sit down and consider their own risk, who should be getting screened for diabetes? What is the age range? What lifestyle components would kind of cause you to consider that? And then what is the actual screening process?
Understood. It's all excellent questions. So anyone over the age of 35 should be considered to be screened as part of their general checkup.
Mm-hmm.
Anyone, and we can all think about our ages, right?
Right.
Anyone younger than 35, and this would still apply over 35, beg your pardon, but someone that you might consider to screen earlier would be anyone that is overweight or obese.
Mm-hmm.
So we could use body mass index to give us an idea to say, okay, if your body mass index is greater than 25, greater than 30, especially if you have a first degree relative with diabetes. If you yourself are of a high risk race and ethnicity, like Afro-Caribbean, also Asians, Asian descent is also a bigger risk. When we look at American Diabetes Association information, they also talk about those of Latino descent, Native Americans, and so on. Not necessarily that we have a large population here for ourselves.
Right.
Anyone that has hypertension, cardiovascular disease, they should be screened. Anyone that has factors that look like metabolic syndrome. So metabolic syndrome is a situation where obese patients have an increased risk for pressure and sugar issue development. So if their waist circumference for men is greater than 40 inches, greater than 35 inches for women, if they have dysregulation of their cholesterol, their good cholesterol is really low, their triglycerides are pretty high, that would be another person to think about. Women who have polycystic ovarian syndrome, because PCOS in and of itself drives insulin resistance and increases risk for diabetes. They put their physical inactivity, but I think that's also in conjunction with obesity to consider. Definitely anyone who has had a pre-diabetes diagnosis should then keep tabs to make sure it's not progressing.
Right.
And any woman who's ever had gestational diabetes, because usually what can happen for many women, they can be lucky in that they can have sugar issues and gestational diabetes during pregnancy. But once they deliver, the placenta is gone, that insulin resistance is gone back to their normal state. And if they don't get a checkup, unfortunately, they may then years later be found to be acutely uncontrolled diabetic because they didn't have that checkup afterwards. So even after pregnancy and delivery, anyone who's ever had gestational diabetes needs to be screened because their lifelong risk for diabetes development is up.
Right. Okay, so you mentioned the age at which people should start, but what is the frequency of screening?
Excellent. I apologize. I didn't answer the other question, the portion of how to actually screen. Beg your pardon. So how often would be at least on an annual basis?
Okay. Is it a part of your annual?
It should be. It should be at least over the age of 35. And again, if you're in one of those categories with the increased risk factors, if you notice your doctor hasn't looked either at your fasting blood glucose, which is another name for sugar, or your hemoglobin A1C. Sometimes you hear people call it just A1C. That's your 3-month sugar average. Those are the major ways that we diagnose diabetes.
Okay.
In gestational diabetes and in some clinical cases, we'll actually do an oral glucose tolerance test, which means we check your sugar before. We have you drink some not so great tasting stuff that's just literally laden with sugar. And then we recheck it an hour or 2 hours afterwards and see how your body responds to that sugar load. So that's sometimes the way we'll do it as well. We do that for sure in gestational diabetes, but for the average person, A1C or the fasting blood sugar.
I remember that. My wife going through pregnancy twice. I do remember that part of it, and it did seem particularly nasty.
Yes.
Whatever that concoction is. So, let's talk about symptoms, because I think, we kind of have an idea of screening, kind of have an idea of some of the risk factors. But if someone is either pre-diabetic or diabetic, especially if they don't know, what are the most common signs? What can they look out for? And then, what may be some symptoms or signs that people sometimes overlook or mistake for something else?
Sure. So common symptoms: increased thirst, increased urination, especially nighttime urination. Truthfully, there can be so many reasons that someone can have increased urination: infection, medication, men as they age, prostate issues, women overactive bladder. But you have to then ask yourself, is there anything, what is actually causing this increased urination? Unintentional weight loss, which unfortunately sometimes, especially for overweight and obese patients, they'll be like, oh, look at that, I lost some weight and I wasn't even trying, and they'll be kind of happy about it, but it's unfortunately an unhealthy weight loss.
Yeah, it's not good.
Exactly. For other major symptoms, beg your pardon, I'll usually hear patients have issues with blurred vision, like they'll suddenly have some vision changes they can notice. Depending on the severity of sugar elevation, they can start to have neuropathy symptoms, which is numbness or tingling to the hands or the feet. Most often starts in the feet. And then increased risk for recurrent infections, especially vaginal yeast infections for women, skin infections that just aren't seeming to heal as well as they used to, because uncontrolled sugars affect your body and how well it can overcome infections. For type 1 diabetics, it can almost be like a thunderclap event when they suddenly get diagnosed, especially for the adolescents. When it's happening, is they can be extremely ill, nausea, vomiting, abnormal rapid breathing, just really not doing well, because it happens and their pancreas is no longer making what it needs to keep them in a good range. So sometimes for type 1s, when they're first diagnosed, it's not just this insidious process. They could have a little bit of that before with increased urination, increased thirst, but then boom, it's there and they're in the hospital.
Right.
Yeah.
Okay. Understood. Are there any silent symptoms people might overlook, especially, I guess, in the early stages if you're pre-diabetic?
Pre-diabetic, for the most part, a lot of patients don't have symptoms. It's most often just found in routine blood work.
Right.
Or they say, oh, my family member has diabetes and I decided to do a finger stick and it was this. What does it mean? Because that can be, again, if it's a fasting sugar, you can use it to know. I think the biggest one is usually the weight loss. In terms of, yeah.
Okay. Yeah. Fair enough. What is the diagnostic process? Like, how, when someone comes in, so like, let's say someone says, well, I've been having, a lot of an increase in urination, or I lost 10 pounds and I really didn't do anything. And they think that they might be at risk. What is the process of going through a process of being diagnosed?
Sure. So when we order the blood work, whether it be you're in that risk group, people who should be screened, or by symptoms. If someone is symptomatic, you can actually use a random sugar at any time above 200. If so they have the symptoms that fit. It's ideal to have it fasting, right? Because then you would actually want, especially if someone doesn't have the classic symptoms. Let's say if you're just coming in for your routine screening, or you know that your grandmother had diabetes and you want to know. It should be fasting blood sugar greater than 126, or the hemoglobin A1C 6.5 or higher. Those are diagnostic standpoints of where someone would be told that they have diabetes.
Okay. I know you mentioned the process for the gestational diabetes testing with the whatever that nasty drink is.
The glucose test, yeah.
Can you just, people sometimes they don't engage with healthcare because they are afraid of what the process might look like. Like, do I have to get a needle stick? Do I have to do this? Do I have to do that? So for our listeners, can you kind of explain some of the standard tests and what the actual process is? So like for getting your A1C or the fasting glucose test, like even just kind of the understanding of what the fasting process means.
Sure.
In a way that, if they're unfamiliar, they can understand what to expect if they're going in and saying, hey, I think I might have an issue, doc, like what do I then need to go into it? What does that look like, feel like?
Understood. Okay. So when you're doing either fasting, plasma glucose or blood glucose, blood sugar test, or the A1C, it's a simple blood draw. So when you fast, it's anticipated that you fast for at least 8 to 12 hours before you come to do the blood work.
So this is when the lab tells you, don't eat anything
fast
tonight,
midnight,
and then
exactly.
come first thing in the morning.
Right. You can still drink water during that time. And I myself, as someone who is really hard to find veins, I actually make it a point to drink water before I go to get blood work done because they just want to use me as a pincushion. I'm like, no, we're not doing this today. So you can drink water, but nothing with, fat or sugar. I generally avoid caffeine products for the same reason. It's going to pull your blood vessels down and make it harder for them to find a good vein to get that blood from. But usually that would be the situation. If, let's say, someone walked into my office and had classic symptoms and they had, we had a really high suspicion, I'll do a finger stick right then and there. Okay. But then I have to ask them, well, when last did you eat, to understand what that means. And
the finger stick gives you what? What data?
I apologize. I'll give you just a blood sugar reading. Okay. So the way that patients who have diabetes that are monitoring it at home, those are finger sticks where they just prick the tip of your finger, get a little bit of blood on a test strip, and we can get a sugar within seconds. So sometimes we'll use that at least as a jumping point, because if they're symptomatic and it's above 200, you've sealed the deal.
Sorry, I'm having a very strong memory of getting my finger stuck like in 6th grade, if I remember correctly. They did a vision test, they did that, and I realized I presume that's a part of just at a national level.
Routine screening.
Right, routine screening, people trying to see, I imagine that's more so for type 1 than type 2. Well, I guess maybe back then, maybe it's different now.
To be truthful with you, I'm not sure if there might even be anything else they're screening for at that time.
Right.
Because, they'll also do routine screening for sickle cell disease and things that are common and not always detected early in life.
Yeah, but I do remember it was 6th grade, and it was a part of the process of like preparing for going into high school.
Into high school,
like that. Yeah. Interesting. I've gotten my finger pricked since then. Let me just make it clear. For some reason, that was just the memory that came back. Less people think about not doing what I'm supposed to be doing. All right. So, one of the things that people like, one of the phrases people like to throw around when it comes to any type of awareness is the idea of like, know your status, know your numbers, things like that. I know your numbers is a particular one when it comes to diabetes.
Definitely.
What are some of well, I guess let's start just at the core. What is the goal of knowing your status and why is that important?
Excellent question. So I always tell patients as a diabetes specialist, I like numbers. Okay. I'll ask you for your numbers all the time, whether it be finger stick sugars you're checking at home, whether it's your hemoglobin A1C, you should know what that is. You should also know when last did you have it checked. And the reason I hone in on those things, and truthfully, apart from sugar, I also hone in on blood pressure and cholesterol. And I'll explain why that's important in a second, is because that translates to quality and quantity of life. I'm not just trying to be nitpicky and, harass you. It's because instead of waiting for that blood test to come back, because hemoglobin A1C, when you're monitoring a known diabetic, it's usually every 3 months. Okay. Because again, it's a 3-month average, right? But let's say if I have a patient that comes to me and their blood sugars are in the 300s, whereas a normal sugar, when you haven't eaten anything, is 70 to 100. When you are a diabetic, that's a high number, yeah. So when you're as a diabetic, your goal in the morning time before you have had anything to eat or drink is to be less than 140. Okay. Later in the day, when it's been at least 2 hours after you've had something to eat or before a major meal, is to be at least less than 180. So if you're walking in here at 300s, that's a problem, right? In terms of what is this going to translate into?
Right.
So again, I tell patients I hone because of quality and quantity of life. Because unfortunately, uncontrolled sugars will damage small blood vessels in the body, small blood vessels that feed the back of your eye. So this is how when patients have uncontrolled sugars, they can lose their vision because they'll end up with bleeding in the retina, which is the back of the eye, the important part that helps you to interpret data as you look. It can cause neuropathy, which can be really painful for patients. It destroys the little, the nerves that are supplying your feet and your hands. People will start to feel numbness, tingling, but apart from that, where they feel like they sat on their foot and they didn't, is trying to wake up, they can have burning, shooting, shock, and pain. They can start, walking into furniture and not feeling it, stepping on a nail and not feeling it until it's turned into a wound that then becomes an infection that then leads to an amputation.
Right. That's how you get into diabetic foot issues.
Exactly. Right. Small blood vessels that supply the kidneys. So, kidney damage, kidney failure at the worst end of the spectrum. And then it can also cause issues with large blood vessels in terms of risk for heart attack and stroke. And that's why, in addition to looking at blood sugars and goals, we also look at blood pressure and cholesterol. We have to look at all of those things together. So I talked about what the sugar goals would be, but also knowing your A1C number. What is my A1C goal? So again, 6.5 or higher is diabetes. For the average person, 7% or less is where we want to be.
Okay.
As we age, so let's say if I have an 80-year-old patient with diabetes, live with 8%. Please enjoy your life. Have a little piece of cake here and there, because that's what life should be at that point, right? And it's also because we have to weigh the benefit and risk with anything in life, and especially in medicine, to say, okay, I want to achieve this golden number, because over time, data, especially that was done in the United Kingdom about what the outcomes would be over long-term uncontrol, is am I achieving that and doing it safely? Because you could achieve that, but you could also put someone in low sugars all the time to get to that number. Because you say, this number looks good, but how did you get to that number?
Right. Because there's so many different components to that process. Yeah. And then, medicine is a practice, right? And so things evolve over time as well.
Yeah.
So you don't know how things like COVID, for example, how that might affect what those numbers are 5-10 years from now, because we always have these different things that come into play. And it's like, well, okay, you have to revisit what these numbers are.
Right.
And so it's also kind of keeping track of that. I guess that's why you said education is a key part of the role, especially as an endocrinologist, because you always want to make sure that you're informed so that you can better inform your patients as well.
Definitely.
Okay. So we've gotten to what I imagine for some people is going to be their favorite part of this conversation. So advancements in therapies. Obviously, Ozempic has kind of become the poster child for not just as a diabetic medicine, but also just as a weight loss solution. To the point where, you had people in rap beefs saying that Drake was on Ozempic, things like that, right? Like this is how far it's gone, right? It really is just out there to that degree.
Right.
So obviously we're hearing a lot about new treatments like Ozempic. Can you give us an overview of these advancements? So this includes that and anything else, and how they're changing diabetes care.
Sure. So insulin was discovered in the early 20th century. Before that, diabetics basically had to starve to live. That's how they managed diabetes. As 20th century advanced and then into the 1950s, metformin came out. So a lot of diabetics or people who have diabetics in the family will know about metformin, glucophage. Those will be different names you'll hear. And even with, as you said, this poster child Ozempic, and we'll talk about some of the other newer medications that are excellent in what they do and the benefits that they can have, metformin is still my go-to. I do not take patients off of it if they come to me and they're already on it and we're trying to get them under better control, because metformin has its benefits. It has been shown in United Kingdom studies. Again, most of these cardiovascular outcome trials, when we talk about the newer medicines like Ozempic, like Mounjaro, like Farxiga, Invokana, Jardiance, which I'll talk about those in a second, most of these patients were already on metformin. So we know that it's providing also a benefit. So I don't take patients off of metformin. But, you know, there are some limitations with all medications in terms of side effects, in terms of when is it safe to use the medicine, when is it not safe to use the medicine. I would say whoever started the marketing for Ozempic, they're doing a good job. Because Ozempic isn't the first of its kind.
Right.
Medications in that class of medications, those are called GLP-1 receptor agonists, have been around since 2005. It's just Ozempic was the most robust in weight loss up until the time before tirzepatide or Mounjaro came out. And it had great benefits in terms of these medications are once a week injections. One specifically is once a day injection. That's Victoza or Saxenda. They help with diabetes control because they're basically giving you hormones called incretins that your gut normally releases when you eat. So you feel fuller faster, you eat less, and you also have a better internal release of insulin related to food intake. But apart from helping with diabetes control, because these are primarily diabetes medications that were then FDA approved for weight loss, that apart from improving diabetes control, they have shown to reduce cardiovascular events like heart attack and stroke, to the point that they've actually studied Ozempic in obese patients with no diabetes that have cardiovascular disease, asking the question, does this improve outcomes in reducing heart attack and stroke?
Oh, wow.
So there are great benefits to them for sure.
This is why it's the poster drug.
Right. But Mounjaro that has come out since Ozempic is slightly different. It's still a GLP-1 receptor agonist, but it's also a GIP, receptor agonist. So it has a bit of an edge in that it can give you a bit more control for diabetes, but also a bit more weight loss. But for those patients and anyone out there listening wanting to know more information about, you know, poster child Ozempic or Mounjaro for the weight loss aspect, because I'm sure some of our listeners might be thinking about it solely from that standpoint. I always tell patients, as I'm sure Mrs. Cambridge will attest to, that if they are considering to use it for that purpose, or even in my obese diabetic patients that want the maximum benefit for the weight loss, you gotta lay the groundwork. You can't continue to eat, you know, Bamboo Shack and McDonald's and chips and sodas and expect it to give you the most benefit, whether it be from a sugar standpoint or a weight loss standpoint. But apart from those medications, other advances have been in terms of medicines like Farxiga, Jardiance, Invokana. These are medicines that came out the first one was approved back in 2013. These are once a day oral medications that have excellent improvement in diabetes control, but they've been shown to reduce diabetic kidney disease. Again, to the point that we are examining them and using them in non-diabetic patients for the kidney benefit, right? They also help to reduce heart failure, hospitalizations in diabetics, again, to the point that we're using them in people with heart failure that don't have diabetes. So I'd say the biggest advancements in therapy that is exciting is that you are seeing, apart from we know, okay, if your sugar is better, your risk is less. They're seeing that regardless of how much it helps the sugar to be improved, it's giving these benefits.
Right. All these other benefits are tied to it as well.
Yep.
So okay, you can correct me if I'm wrong, but from what you said, my understanding then is that the biggest difference with the newer therapies like Ozempic and others is that they offer these additional benefits in areas like potentially heart health, kidney health, and that's really the main difference between them and a more traditional therapy like metformin.
Right. However, I want to make it clear that I think a part of that has also been a shift in how the FDA approves these medications. So years in the past, there was a particular medicine called rosiglitazone that was approved and used for diabetics, but we actually came to find out post-marketing that it was hurting people and causing heart disease.
Oh no.
They had to take it off the market.
Right.
So since that happened, any new diabetic medication that wants to come out and that the FDA has to approve has to run cardiovascular outcome trials to prove that it is, first, obviously not going to do any harm, and then two, ask the question, is it going to give benefit?
Right.
So I think part of it is also just that shift that allows us to see this more. But it's important because, again, those are the big, large vessel consequences of uncontrolled sugars and uncontrolled diabetes.
Okay. So, you know, we've had Shanishka kind of sitting on the sidelines for a lot of this conversation, but we we are now firmly moving into your wheelhouse, and that's the conversation around lifestyle changes as a part of therapy. So you've mentioned lifestyle here and there. I think the quickest and easiest translation for that for most people is diet and exercise.
Right.
But we know lifestyle changes are a big part of conversations around most disease management nowadays, regardless of what it is. So for you, from the dietary and nutrition standpoint, what are some of the most impactful changes that someone can make in order to help manage their diabetes?
Thank you, Mr. Burrows. As you mentioned, lifestyle changes are very important for the management of diabetes. As it relates to nutrition, I want our listeners to note that leading experts in the medical field, in the health field, have always and more so beginning to more recognize the importance of dietary changes. For example, there was a study published in the Lancet in 2019, and they stated that the leading cause of early mortality and morbidity globally, which means dying earlier and developing chronic conditions or their complications, was a suboptimal diet. So, in other words, the Lancet said that eating an unhealthy diet was the leading risk factor for early death and development of chronic conditions around the world. This is not a surprise because the statistics have shown for a while that the leading cause of death is heart disease. And for persons who are diagnosed with diabetes, they more likely will die from heart disease than from high blood sugar. So this conversation about lifestyle changes and diet is very important. I want our listeners to also recognize that though the research is pointing to genetic risk factors, there's also research that indicates our lifestyle habits can impact the expression of those genes. This is referred to as epigenetics. And so for those persons who are interested in that, they can look it up, EPIGENETICS. I'm an educator at heart as well. So epigenetics refers to how the environment, such as our diet and our lifestyle, impacts the expression of genes. So if you have a family history of diabetes, you may have a gene that predisposes you to that, but epigenetics has informed us that it is behavioral choices that has a major influence on whether or not those genes will be expressed. So you asked a question about what can we do and how impactful can it be. When I am visiting or I'm seeing a patient, I want patients to have a well-rounded overview of what they need to do. Yes, persons come into the clinic and they want to know, tell me what to eat, what supplements should I take, and I always want to steer them to that holistic point of view. And the main thing I want to know is that the main reason that persons enter the clinic for diabetes management is for type 2 diabetes. So in my experience, though I see patients who have type 1 diabetes, primarily the patients who are entering the clinic have type 2 diabetes. And they must understand that this is a lifestyle related condition. And so it must be addressed not just by diet, which is a part of the lifestyle, but other factors. So Dr. Cartwright would have mentioned that when it comes to type 2 diabetes, there's a phenomenon called insulin resistance that is underlying that particular disease process. And insulin resistance, she would have explained, is simply means the body's has the insulin, but there's a little challenge in it responding in a timely fashion, and so the blood sugars elevate. But what is fueling this insulin resistance, and how does lifestyle play into that? Some things outside of diet that we want to be taking into consideration is sleep. Inadequate sleep increases insulin resistance as well. Stress increases insulin resistance. So when I'm working with patients, while I address the diet, I also want to address those other factors: rest, stress management, sleep, in addition to exercise. And just to add a bit more to this conversation, from a dietary point of view, the research has been providing additional insights as to what is happening on a biochemistry level. Initially, early in this program, I said that I started off as a biochemist. And so always interested in finding out what's happening at the deeper level. And so one of the questions we'll ask is, what is fueling this insulin resistance? And there are a few things, a few answers that came up in the research. One of them would be the consumption of high-fat diets. Now, some person be listening and they say, but hold on, Mrs. Cambridge, you're supposed to be talking about sugar and the carbs and the starch. We're supposed to stop eating rice and just eat salad and meat. How does fat come into the conversation? But trust me, go on the internet, search up Yale University insulin resistance, fat, and you will find that there's research that is showing that when a person consumes high fat diets, we call it grease, right? High fat, greasy foods, it is actually fueling this insulin resistance and it's interfering with how the insulin receptors are interacting with the insulin. So, one of those dietary changes that is essential is yes, while we need to know about carbohydrates and starch and sugars, we also need not neglect the saturated fat or the greasy foods because the research does show that it can influence the inflammation and the insulin resistance. So another thing that we want to look at is if you have diabetes, whether it's type 1 diabetes, type 2 diabetes, or if you're at risk, if you got pre-diabetes, it's important that if you want to get the most benefit from your dietary changes to seek the help of a professional, right? Everybody's online, they have all kind of information, everybody's the expert. But when we think about the complications of diabetes, the eye complications, the problems with our feet, blindness, kidney failure, we don't want to be wasting time. And what I help patients with at Oak Tree Medical Center is helping to develop protocols based upon medical nutrition therapy. So the American Diabetes Association has said that there's strong evidence to support that medical nutrition therapy is very effective in diabetes care and it should be integrated into the management. And I'm happy to say that my experience at Oak Tree is that many opportunities are available to me to assist patients who have this particular condition. So they may ask, but medical nutrition therapy, what is that? I've never heard that term before. And I'm glad to briefly just mention that it is a form of individualized nutrition care where a specialist, for example, a registered dietitian, would analyze not just what your blood sugar level is, but also what medications are you taking? What is your lab saying? What are the other diagnoses that will impact and influence what it is that you have to eat? Because every patient is different. You can't just say, well, give the same so-called diet to everybody, but everybody has a different age, a different height, different medications, different lifestyles, different labs. And so all of these things are taken into consideration with medical nutrition therapy when a care plan is being developed. And so when this care plan is being developed, it includes education, behavioral counseling, because sometimes we know what to do, but it is challenging sometimes to do it. And so some of the advice that I give to patients is, well, let's use SMART goals, right? So SMART goals, let's be specific, let's be measurable, let's be achievable, let's be realistic, let's be time bound. And so you may not be ready to reduce the greasy foods, right? But you may be ready to exercise. You know, be ready to reduce the sugar sweetened beverages, but you may be ready to implement what is called the plate method. And so the plate method is another dietary lifestyle change that sometimes is a bit easier for patients to try initially. So that's like saying, look at your plate and cut it in half, and half of it is non-starchy vegetables. We're talking about things that we are familiar with, like lettuce and tomatoes, or we may have some cabbage, or the broccoli Normandy in the frozen section, the broccoli, cauliflower, and carrots, and fill up on that. Because when we do that, we're helping to reduce what is called the glycemic index of our meal. So addressing something called the glycemic index, persons can look it up. As well, is also an important component with dietary changes, and which simply means that what is the response to my blood sugar after eating food. There's certain foods that we consume, certain drinks that we consume. When we ingest them, the blood sugar rises more quickly than others. And so the half a plate of non-starchy vegetables that I've mentioned, like the lettuce and tomatoes, the broccoli Normandy in the frozen section, those are lower on the glycemic index. So they would have a less of a glucose response in terms of a rise, and that's very helpful. And of course, we love our starch. I don't promote that all patients say, well, I'm going to eliminate starch. And it's for a number of reasons. When we look at how the body functions, the main fuel for the body is blood sugar, right? And I don't believe God made a mistake in doing that. And so we do need to consume foods that turn into blood sugar. But I believe that because we have veered away from healthy lifestyle behaviors, we have developed overweight and obesity, extra fat in the body, we're more sedentary, i.e., lazy, don't want to exercise, we have lots of stress, we don't rest, and do all of these things, then it makes our bodies less able sometimes to process these carbohydrate containing foods that turn into blood sugar. However, it is important for persons to realize that a balanced, healthy diet will include all of the food groups, which include carbohydrates that may have a higher amount of starch in them. But using the plate method, we can portion control. What is portion? You eat till you're full, right? We can portion control and have maybe a quarter of that plate with the starches and use things that we are familiar with. We have our cassava, we have our pumpkin, the peas and rice. Though some patients, they want to say, well, I eat white rice, not peas and rice. And I always ask them, why? Why are you saying that you don't eat peas and rice? People just believe that peas and rice must be terrible, and I've come to learn that maybe they're thinking that, oh well, the only time I eat peas and rice is when they put all the salt beef and the meat and stuff in it. But you don't have to cook the peas and rice like that. You could cook it without the extra high fat, saturated fat meats in there. But the peas, those peas and those pigeon peas, those are very low on the glycemic index. They are very high in fiber. They are able to promote satiety. And so all of these things are going to be helpful for blood sugar control. So when you think about Ozempic is working because it promotes satiety. It helps people feel like they are full or they don't want to eat food. But there are also other foods that we can also put on our plate to promote that naturally, which include the peas and the legumes that could be in the peas and rice, or we can add it to our salad. And so I just wanted to let persons know that, hey, there is hope, right? We don't have to feel as if, well, I'm going to die, have diabetes, I'm going to die. You don't have to die today, right? I can't say when you're going to die, but what I can empower you to know is that there are things that you can do to make changes to make your blood sugar control be more effective and have a better quality of life.
Right. It's interesting. My wife and I, about 2 years back, went through a time frame of basically being whole food plant-based. And we did it for, I want to say probably about, the intention was to kind of do it for a fairly long time. I think we ended up doing it for about 6 months. And in that time frame, I actually lost 40 pounds. So, we weren't, that's the thing, we never really added in any sort of intensive exercise. It was literally just the dietary change. So I can speak for myself from experience, that alone. Now, granted, that's not for everybody. And it is sometimes difficult to maintain. I know getting just in eating only plants and whole food plant-based is quite an expense, but at the same time, there are a lot of ways that you can kind of take that approach. So I'm appreciative of that conversation, because I think sometimes people sit back and they think oh, it's just such this massive adjustment, right? But there are little changes that you can make around the different areas of it to make it easier and to help. So, if you are a diabetic and you are on something like Ozempic, like you said, you're doing your best to kind of make the lifestyle changes in addition to that, because then you don't necessarily want to have to be on a medication if you don't have to be, right?
Correct.
And so you kind of partner the dietary change with the medications to kind of get the best of both worlds and to try and get yourself off of the medication eventually, because I think that's ultimately what people would want, is to not have to be reliant on a drug.
I thank you again, Mrs. Cambridge. That was excellent. So you can see what data a nutritionist can give, right? Yeah. So when I see new patients, especially new diabetics, on average, my visit is anywhere from 40 minutes to an hour because of the amount of information we're going to want to talk about. And even then, I'm only scraping the surface of what a registered nutritionist and dietitian like Mrs. Cambridge can really afford to patients. Because I'll talk about the plate method. And patients will often tell me, oh, doc, I can never eat carbs again. I'm like, that's really not the goal here. Right. The problem is we as Bahamians, we don't understand portion control. No, we don't. Right? A Sunday dinner is peas and rice and macaroni and potato salad and plantain. Right. And chicken, and somebody made a pasta and salad in terms of the carbs, right? Or you'll have a patient that'll say, oh, doc, I really changed to how you mentioned plant-based. If you're a diabetic and you then make like a boil, right? With like ham and potatoes and cabbage and carrots, but then you tell me you also got pumpkin and cassava and the white potato or the sweet potato, and the majority of what you put in your bowl when you eat are those carbohydrate dense vegetables. It will still be a healthier thing because, as Mrs. Cambridge said, fatty foods are going to drive even further insulin resistance. So you're helping yourself there, but you're kind of shooting yourself in the foot in that you're eating too much of that particular portion of carbohydrates. Right. So I think she brought up an excellent point that for some patients, it can be really daunting when they first hear the diagnosis to say, well, how am I going to change my life? Because obviously, yes, lifestyle changes. The goal is to help, obviously, your outcomes, but also we can lessen your medication burden. I want that for patients, right? We all want that for ourselves or our loved ones, our friends, our family. But we have to, do our best to actually lay their groundwork. So I suggest to all diabetics, see a nutritionist when first diagnosed and every couple of years. Like, let's say if someone tells me they've been a diabetic for 20 years and this is the first time I'm seeing them, I'm going to ask them, when was the last time you sat down with a nutritionist? Because it doesn't hurt to get a refresher. Right. Especially if, things have kind of changed in life, more stress, you find it hard to keep up with what you were previously able to do. It's time to go back and revisit education with them.
Okay. Yeah, I think every conversation that I've ever heard, especially in recent times around this topic, that's always a big chunk of it is that area of lifestyle changes, dietary and exercise. So it's very important information to kind of add into the conversation as well. As we wrap up, you can't really have a conversation about medicine nowadays without talking about advancement in technologies. Obviously, we talked about it from a medication standpoint, but I know there are a lot of different technologies out there for monitoring, things like smartphone apps, different devices, things like that. Because obviously, it used to be, I think, just the finger prick is what most people would do. But how is technology impacting the whether it's the diagnostic process, the treatment, and the management process of diabetes?
Excellent question. So I would say for the majority of diabetics, for the technology that we would talk about and that they should consider, especially if they are a diabetic on any form of insulin, even let's say they're a type 2 diabetic just on one insulin shot per day along with tablets, definitely if they're type 1 diabetics. And then there are actually new varieties that have been FDA approved, specifically the Dexcom Stelo, which is the first continuous glucose monitor. You hear people say CGMs, that you can get over the counter in the States. So for pre-diabetics or diabetics that are only on oral medications, they can wear it. Okay. But I think the advancement can be diagnostic for some patients because A1C, the hemoglobin A1C, there are limitations to it. Okay. So when you check hemoglobin A1C, it's looking at sugar stuck on the outside of blood cells. If you have some disruption in those blood cells, let's say you don't make enough. Let's say you are a menstruating female, you lose too much every month. You have kidney disease that also affects the blood cells. You have chronic liver disease that can affect how well the sugar sticks to the blood cells. It can make A1C look acceptable, but it's not real in terms of it's not accurate. Whereas continuous glucose monitoring can allow us to get real-time data. The same way Mrs. Cambridge was talking about, setting goals and realistic goals, time frame for those goals. When you use a continuous glucose monitor, and even let's say if we don't have access to it, because they can be costly. Most of them are actually covered by insurance. We have to do our legwork in the background for us as physicians and my support staff to get them approved. And we want to see those numbers in real time. Because let's say, for instance, again, you come to me as a brand new diabetic. I'm not waiting 3 months, especially if you're very poorly controlled, to really know, are you better? Exactly, no. Whereas finger sticks or the continuous glucose monitoring can give you real-time data. The continuous glucose monitoring devices, you have Freestyle Libre 2 and 3 available in country. For our listeners, anybody that might be on Freestyle Libre 3, they did recently have FDA recalled a batch of sensors in September, unfortunately, because they were falsely giving higher numbers than were real for the patient. I know. And then there's also Dexcom G6, G7 available in country. So I'll tell patients, if you consider to do a continuous glucose monitor, and I think at some point, we as a community in endocrinology will probably move away from relying as much on hemoglobin A1C as more and more people get devices, because you can use time and range. It's a percentage that says, okay, how often is your sugar between 70 and 180? And if we achieve 70% or higher, that equates to an A1C of around 7%. So we can use that in real time rather than waiting 3 months to know. There are limitations to continuous glucose monitors, though. So several limitations would be at the extremes. They're not always as accurate. So if you're Freestyle especially is notorious for it, in that about 20 to 30% of the time it can overestimate a low. In that it's going to ding and alarm you that you're low, but you're not actually low. So I tell patients when they're on continuous glucose monitors, don't throw away your old school glucose meter for finger sticks. You still need it around. That way, if that happens, you're going to do a finger stick and see if it's accurate.
Yeah, because then you have the ability to confirm, right?
Exactly. Because when you wear these continuous glucose monitors, Freestyle Libre currently only FDA approved to go to the back of the upper arm. G6, the Dexcom G6 approved for the abdomen or the arm, G7 for the arm. And they say approved because that's where they studied it for FDA approval. But I've had patients use them on the belly, even though they're not approved there. You would do the finger sticks. I apologize. I lost my train of thought for a second. You would do the finger sticks to be able to say how accurate is this in this moment. But when you place the CGM, back on my train of thought, there we go. It is a small piece of plastic that stays just under the skin. So it's a needle that puts it in place. Once it's in your body, it's a small piece of plastic, almost like when you get an IV line. But it's not in your blood vessel like an IV line. So there is a bit of lag time between what's happening in your blood and what's getting out to that fluid out around the cells. So that's why we'll say sometimes if it just doesn't make sense, do a finger stick. I will say the Dexcom G6, G7 do have the option to calibrate. So these machines actually come factory calibrated in that you shouldn't have to calibrate them. But they do have the option that when you first put on a new sensor, you could do a couple of finger sticks periodically and tell the sensor what is your finger stick. So it can get more accurate during the time that you're wearing that particular sensor.
So you're getting to add input data into it to kind of make sure
that it's actually tracking along with what the blood sugars are actually doing. But I would say the biggest limitation that I see in our community for it is, for some patients, is acceptance. They're not open to wanting a device on their body. Which I tell people that's their personal preference. If that's not the case, then finger sticks it shall be, and that's okay. And then the second would be cost.
I mean, we do tend to be, generally speaking, an old school conservative type of population. So there is that, I still have friends in my age bracket that don't want to have like a debit card even. Like they'd still want to or they want to have a credit card. They just want to be able to just take the cash. Put it under the mattress, that sort of thing, right? So we do tend to be that way. But I mean, from your standpoint, how are these types of devices and this type of technology helping to, make it easier for people to manage their day-to-day, like the condition day-to-day?
I would say it makes a huge difference. In the same way that Mrs. Cambridge talked about medical nutrition therapy improving outcomes for patients, it's been shown that self-monitoring of blood glucose with finger sticks and now translating to continuous glucose monitors makes a big difference for patients. Because again, it's one thing if I tell you, okay, your A1C is 7.9%. You are diabetic. We're going to try oral medications, lifestyle changes. But if you are not ever asking the question, what is my blood sugar after certain meals, then we could very well be missing a big part of what could be early targeted changes in your lifestyle, which again can prevent the progression, reduce your medication burden. So I think it makes a big change in that it gives you real-time data, whereas some patients have a hard time doing finger sticks. I have some patients who have a complete phobia of finger sticks, so this is a great alternative.
Right.
In terms of apps, so Dexcom has app capability, so does Freestyle. Some of these devices, you have to, put your app store to a VPN or make it look like we're in North America for it to link. But then you're fine in terms of that aspect working. And I would say some of the downsides to the CGM is some patients get alarm fatigue. So especially with these newer ones, it will alarm you if you're starting to drop or alarm you if you're starting to rise. And if you constantly have an alarm going off, eventually you're going to just block it out. So there's some alarm fatigue that can happen for some patients.
It can be stressful.
Yeah, it can be. It definitely can be. I myself have worn devices before when I was in training because it allows us to know what it feels like, right? So we can share that with patients. And then apart from continuous glucose monitors, you also have insulin pumps. So insulin pumps will more often be for type 1 diabetics, where there could be some type 2 diabetics that we would consider that in. And basically what it does is instead of you having to do, up to 4 times per day injections, you have a device that actually administers the insulin. The only thing I always hesitate when I talk about these devices with patients is when you're considering a pump, it isn't that the pump suddenly works. We are not yet at an artificial pancreas. We're getting there in terms of the technology. We will get there.
Right.
But they still have to talk to the pump. They still have to say, okay, well, I'm going to eat this many grams of carbohydrates because I have this much rice and, potato salad on my plate.
Right.
So you still have to talk to it. You still have to tell the device what is your sugar, whether you do a finger stick or have a CGM communicating with it. So it's exciting. The technology is exciting for sure.
No, I mean, and I think that's the thing. One of the things that has come out of this conversation, and a lot of others, is the importance of early detection and then the ability to intervene early, right? And so I imagine in the space of being able to continuously monitor things like that, it gives you that ability either as the patient or for you to do something about it yourself or to allow you to know, hey, I need to contact my physician to kind of get intervention very quickly if it's something that's more catastrophic or more drastic.
Right.
So that's always helpful and beneficial in the space of managing any disease or any disease process. This has been a great conversation. We've covered a lot of ground. I want to thank you both for taking time out of your busy schedule. It's always kind of an interesting dynamic to get multiple people in the healthcare space into a room at the same time to talk through things like this. But I'm very appreciative of the time that you guys were able to set aside. And, I invite you, if someone is concerned, if they think they may be diabetic, how do they contact you? How do they get in contact with you? How do they set up an appointment? If they feel like they want to come in and sit down and go through the process of getting checked, what does that look like?
Sure. So I'm predominantly at our Collins Avenue subspecialty clinic. The telephone there is 605-2030 or 605-2031. I would encourage any patients that do want to see me in that regard, if they've had recent blood work done, bring it with you, right?
Okay.
So that way it can give us the most benefit for the conversation. And then, if they haven't had just a general checkup in years, I would say that's a good place to at least start, right?
Start with the annual.
Exactly. Start with your annual and understand where things are. But, we are more than wanting to help patients that need the help in the community. And Mrs. Cambridge is at our East Street South location, which I do not remember the phone number offhand, but Mrs. Cambridge, do you remember the number offhand?
Yes, the telephone number you can get Oak Tree East Street South. I have 825-4674. That is a cell phone number. So for those persons who have WhatsApp and they want to call on WhatsApp, that's possible. That's 825-4674. That's the number that I have on me at this time.
I think there's also 3567091 is also issued south. That's the main line, 3567091. All right. Thank you both so much for your time.
Thank you.
Thank you for joining us today on this important conversation about diabetes. A huge thank you to our guests, Dr. Carmen Cartwright and Mrs. Shanishka Cambridge, for sharing their expertise and insights. If there's one thing we hope you take away from today's discussion, it's that managing diabetes isn't just about medication. It's about awareness, prevention, and taking control of your health through sustainable lifestyle changes. If you enjoyed today's episode, please share it with friends and family, and don't forget to subscribe to Vital Voices for more conversations that matter. Until next time, stay informed, stay proactive, and as always, take care of yourself and each other.